Hi, I'm Dr. Rachel Tate, presenting from Rheumatology Winter Clinical Symposium in Maui, Hawaii, and today I have the distinct pleasure of interviewing one of our fellows, Dr. Sheetal Patel, who's coming to us all the way from Michigan, so I'm sure she's very happy to be in Hawaii today. Sheetal, tell us about your poster.
Sure. Hi everyone. My name is Sheetal. I'm a first year rheumatology fellow from DMC Henry Ford University, and today I have a very interesting case on multicentric reticulohistiocytosis. It's a very rare disease, and it very commonly gets mimicked with rheumatoid arthritis. So we'll talk about how we can distinguish both of these diseases today. Um, we'll start off with our case, who is a very young actually, African American female who had a history of a couple years of inflammatory seronegative arthritis, and we were treating her with methotrexate. And eventually she came to our clinic with very worsening joint pain and swelling for a year, followed by 6 to 8 month history of these skin nodules, which were papillonodular in character, started off on her forehead and gradually spread all the way down to her body. Um, as our workup, we ended up doing more serology on her. She was positive for ANA, SSA, and her inflammatory marker CRP was quite elevated. Followed by that, we ended up doing some hand x-rays to try to compare her hand and wrist x-rays from previous year, and we were very astonished with what we found. Within 1 year, this lady had very aggressive, destructive, symmetric erosive disease, not just around her wrists, but around her PIPs, along with DIP involvement. So this led to us to work very closely with our dermatology colleagues. We went in, and I'm very grateful that they were able to get a good biopsy of the node. And the biopsy basically was very helpful for our diagnosis. It basically showed plenty histiocytes here, multinucleated giant cells, very irregular looking nuclei with a prominent nucleoli. And as you can see, the picture is mostly pink. There's a lot of eosinophilic cytoplasm within the histiocytes. And together with the staining, along with the palisading pattern of the histiocytes, we were confident to say that this was more consistent with reticulohistiocytosis. So it's such a rare disease. My attendings have even told me I will probably never come across another case like this, so it's once in a lifetime. And when I was doing more research on this, we found that there are no guidelines. There was no structured treatment guideline for this. So I saw a lot of case reports on the very commonly used drugs are methotrexate and prednisone, followed by a couple case reports of TNF inhibitors. And lastly, very sparsely, I found some on anakinra, tocilizumab, along with rituximab as well. So based on, of course, the patient's preference and her insurance and keeping the whole socioeconomic background in mind, we decided to start off with the etanercept, which is a TNF inhibitor. Since she was already on methotrexate and it was not really controlling her symptoms, so we were hoping the TNF inhibitor can help us control not just her aggressive arthritis, but also her skin lesions, because she is a young female after all. And a couple important points to keep in mind. Number one, MRH, multicentric reticulohistiocytosis, is 1/3 of these cases are associated with malignancy. So we did a thorough malignancy workup on her, including CT, chest, abdomen, pelvis, along with SPEP, UPEP, you name it. We found some abnormalities, but not consistent enough to go forward with a malignancy. So we'll have to keep a very close eye on her and monitor her yearly or 6 months or so. Number two, this disease is quite commonly confused with rheumatoid arthritis. So I wanted to bring up at least 3 or 4 points how we can help differentiate the two. And even though it's a rare disease, it's good as a physician to keep this behind our mind so we know the next time we see some similar pattern. So number one, in rheumatoid arthritis, you'll have sparing of the DIP joints, whereas in MRH, you may have DIP involvement along with the other joints as well. Number two, even though we know that with uncontrolled disease for years, rheumatoid arthritis can eventually lead to mutilating, aggressive, sort of destructive pattern, whereas in MRH, it's very aggressive in a very short period of time. So we're talking about months or even within a year, and we saw that in this patient. Now, most of the case reports I went through said that after the first 3 years of having arthritis is when you present with skin lesions. In our case, this was a little unusual. She had arthritis for 10 years, followed by the skin lesions. So something to keep in mind. And lastly, it's about the papillonodular skin lesion itself. In rheumatoid arthritis, the nodules are mostly around the joint areas, whereas in MRH, it could be anywhere. Like in our patient, it started off on her face and then gradually spread all over her body. And as you can see in our picture, I just have pictures of her hands, but she also has periungual involvement, which is interesting to see. So overall, I think those were the important points I took from this, and I'm very grateful for RWCS to give me this opportunity to present this case and network. So thank you.
Well, Dr. Patel, are you going to be writing some of these new guidelines for the treatment of our MRH? You did. Well, thank you again for letting us talk to you today. Great poster. As always, check out rheumnow.com for further information and for this and other poster presentations from our amazing fellows.